My name is Taylor Harris. I'm one of the sports medicine surgeons at EmergeOrtho, practicing in Asheville, North Carolina. I specialize in arthroscopic procedures. In particular today, we'll be talking about meniscal injuries that are commonly managed in this minimally invasive manner. So meniscus injuries largely encompass two varieties, both medial and lateral. Oftentimes we see these as concomitant injuries with other ligamentous or tendinous injuries commonly seen with athletes playing sports. Additionally, as the knee develops some early arthritis or degenerative changes, these meniscus tears that function as shock absorbers take more of the stress, which can lead to tearing. The meniscus structures, both medially and laterally, are the shock absorbers as previously mentioned. These meniscus structures can tear in various planes and locations that then cause mechanical catching, popping, and locking through range of motion to the knee. Occasionally these are seen with other injuries, but oftentimes can be in isolation. Symptoms with meniscus tears oftentimes lead to tenderness at the joint line, which would correlate with the inside or the outside of the knee, depending if it's a medial or lateral tear. Other symptoms commonly are the mechanical type symptoms, such as catching, popping, or locking of the knee, as the meniscus tissue that is torn gets stuck and clicks through function range of motion. Several populations of patients are at risk for meniscal injuries. Certainly athletes, when they have other injuries to the knee, such as ligamentous or tendinous injuries, increase their likelihood of developing meniscus injuries. Other patients that are active later in life can develop injuries with various twisting and traumatic episodes. And lastly, as the knee develops early arthritis, the joint space is narrow, the cartilage is stressed, which leads to the meniscus working in ways that it shouldn't, oftentimes resulting in tears. Oftentimes, after initial episodes, I tell my patients if it's been 48 to 72 hours and the mechanical symptoms and pain at the joint line have not gone away with activity modifications as well as over-the-counter anti-inflammatories and Tylenol, typically coming in to see us is best. Timing of these injuries is critical because whether the meniscus tear is repaired or a partial meniscus excision is performed, earlier detection and treatment can help preserve what functional meniscal tissue is left. As most injuries in sports medicine, the initial diagnosis starts with a detailed history and physical, followed by x-rays that, for meniscus tears, overall look at the joint spaces. This helps to see any degenerative or early arthritic changes that may be leading to the meniscus tears. If clinical suspicion after these steps is concerning for possible meniscal pathology, an MRI oftentimes is the way to look at the internal structures and confirm the diagnosis. Similar to other injuries, both conservative non-operative options as well as operative options exist. Typically small tears or tears that clinically do not result in mechanical symptoms can be first treated with modifications of activities, physical therapy to strengthen the secondary muscles of the knee. And if the tear is small or in a location that doesn't block the function, this non-operative treatment can be a success. When conservative treatment fails, oftentimes operative intervention is required, which largely is the arthroscopic or minimally invasive techniques where we either repair or partially excise the meniscal tear. The analogy I like to use with my patients is imagine if you had a hangnail on your finger and you kept sticking your finger in your pocket. The treatment for your hangnail would be to snip it off. Oftentimes that can be what we perform during the operation. The other side of that would be if the meniscus tear is in a younger patient or a location where the blood supply will allow healing, we oftentimes perform a repair. But it's all based on the ability of the meniscus tear to heal, and not so much our personal preference or what we believe to be best. The ability to reduce meniscus injuries largely would be keeping the secondary strength and structures around the knee optimized. This would be continued activity, physical therapy, as well as avoiding certain high-impact activities later in life with early arthritic changes that could develop. Lastly, one of the most common ways to reduce meniscal injuries is limiting the amount of force across the knee. Sometimes this can be optimized with weight loss, which can be secondary to a variety of treatments from diet to exercise, as well as new pharmacologic measures that greatly enhance this ability. Early diagnosis for meniscal injuries is critical. This helps to salvage and save the amount of meniscal tissue that's functional. As I mentioned earlier, oftentimes the tear is in a location that has a very poor blood supply, or the geometry of the tear is one that will not heal. These are tears that we excise, but if it's detected earlier, the amount of tissue we have to excise is less, and the amount of tissue that is still functional increases, which optimizes the function of the knee. To the same token, if we diagnose this early and the tear is in a location with blood supply that can heal, getting to them sooner so that we can perform the repair and not have this blood supply jeopardized is critical. Meniscus surgeries that we've discussed today are typically performed in the outpatient surgery center setting. People go home the same day. Physical therapy begins within 3 to 5 days. And depending on the partial excision versus repair, recovery can be 4 to 6 weeks versus 3 to 4 months. Here at EmergeOrtho, we have fellowship-trained surgeons providing quality of care. But we also do this quality of care in an outpatient surgical center setting that greatly diminishes the cost compared to your more traditional hospital environments.